So here you are watching Coblation adenoidectomy in a 9-year-old child. I have just performed tonsillectomy, grade 3 to grade 4 tonsils and similar almost grade 3 adenoids. Now you can see the endoscope is through the nasal cavity. The plasma wand is through the oral cavity, which is bent by almost 35 to 40 degrees. And at a setting of 9 for ablation and 3 for coagulation, we are melting the adenoid tissues completely. This is the eustachian tube. We are melting the adenoid tissues layer by layer completely. That's the superior boundary, which is the periosteum below the sphenoid bone. You can see the periosteum very well. And the superior boundary is completely delineated. Once you go till the boundaries, adenoids will never recur to the extent that they require a surgery again. You see, this is the periosteum. You are not supposed to open up the periosteum. You are only supposed to reach the periosteum. As we further go inside, we are reaching the posterior boundary, which will be the buccopharyngeal fascia. This is the lateral boundary. Lateral boundary anteriorly is the torus tuberis. Can you see this is the torus tuberis? And we still have some lymphoid tissue on the torus tuberis, which I am removing. This is the lateral boundary of the adenoids in the anterior aspect. This is the eustachian tube, is the torus tuberis. And here we are reaching the fossa of Rosenmuller, which is the lateral boundary posteriorly. So that's the fossa of Rosenmuller. And as we further keep going deeper, we will reach our posterior boundary, which will be the buccopharyngeal fascia. In a moment, we'll start seeing buccopharyngeal fascia very clearly. This is still the superior boundary. You see, that's the buccopharyngeal fascia at the back. Once you reach your boundaries, then as I said earlier, you will not get recurrences. So now I'll further define the buccopharyngeal fascia. That's the lateral boundary. That's the Fossa of Rosenmuller completely cleared. And this is the inferior boundary, the Passavant ridge. You can see some lymphoid tissue ending over here. This is the Passavant ridge. Let me focus my camera a little better. All right. All right. So that's the last layer of the lymphoid tissue on the buccopharyngeal fascia. This is the Passavant ridge in the lower part, and I'm defining the buccopharyngeal fascia everywhere. As you can see, laterally you have to be a little careful. You can see that's the buccopharyngeal fascia. I have removed all the lymphoid tissue, that's the fascia. Now you are seeing the fascia very, very clearly. You're not supposed to open up the fascia, only define it. And whatever little lymphoid tissue is still over there, do not open up the fascia, just remain close to the fascia. If you open up the fascia, the child will have pain on lifting the head for a couple of weeks. Obviously, you do not want it. Now, whatever little tissue is there on the torus tuberous, if you do not want to ablate, you can simply coagulate so that the active lymphoid tissues will not be left anymore. They will fibrose. Alright, so that's the end of our surgery. And suppose if there is any little bit of lymphoid tissue in the corner, you can coagulate it. Do not ablate the corners because you can have a vessel which might bleed. Now the surgery on the left side is over. Now I'll go from the right side. There is deviated septum on the right side. I'm going to do DNS as well. Let me see if I have some space to reach below the DNS. Yes, I do have. I'll complete the adenoidectomy. Can you pour some water, sister? And you can see the wand is now getting exhausted. That's the torus tuberous, that's the eustachian tube, right? So I will take care of this lateral boundary, the torus tuberous, very superficially. This was the, can you pour some saline? So the superior boundary of the adenoid on the right side. Thank you. That's the torus tuberous. You can see how much of adenoid was still there on the torus. Alright. So only submucosal and 5 millimeter away from the eustachian tube orifice. That's the eustachian tube orifice. I'm going to remain 5 millimeter away and I'm only removing the lymphoid tissues. I'm not damaging the muscles at all. And this trajectory as the superior boundary completely defined, and this is the lateral boundary. Anteriorly, as I said, was torus to varus, and when following it back, I'll reach into the fossa of Rosenmuller. That's the fossa of Rosenmuller. Lot of lymphoid tissues here, which I need to ablate. As I said, the wound is getting exhausted. That's the fascia. That's the fascia. If I need another wound, I'll open it up. I have kept it ready. Let me see. And that's the lateral extension. That's the fossa of Rosenmuller. Very carefully, this wound is almost exhausted now, but my work is also almost complete. That's the passivant ridge. Because I have already performed tonsillectomy and adenoidectomy with this wound, so naturally the wound is bound to be exhausted. So deep laterally, never go blind because then you can have some bleeder which can trouble. That's the passivant ridge. Almost every bit of adenoid tissue is removed. And hopefully this child will not have trouble with tonsil and adenoids again in life. Thank you for watching.